So I will introduce our guest speaker, Dr. Wesley Francis, who I met a number of years ago when he was also on our board of directors. But I think he's so busy now. So we're grateful to have him here tonight with us. Dr. Wesley Francis is a graduate of the University of the West Indies Mona campus. He did his surgical residence at Wayne State University in Detroit, Michigan, and completed a surgical oncology fellowship at Tom Baker Cancer Center in Calgary, Alberta. He is currently the chief of surgery at Princess Margaret Hospital and consultant surgical oncologist. He also serves as the director of the Bahamas National Cancer Registry. So without any further delay, I will turn the floor over to Dr. Francis to get started with his presentation. Thank you for joining us, Dr. Francis.
Thank you, Rochelle. I want to thank the organizers for inviting me again to give a talk on gallbladder and bile duct cancers. First, Rochelle, I'd like to say I got to update that little short bio. I'm no longer the chief of surgery at PMH.
Oh, okay.
And give that one up. But most of the other stuff is accurate.
Good.
But thanks again for allowing me to give this talk. It's gonna be well, I have a short outline. I can move forward. So we're going to talk about the epidemiology of gallbladder cancer, risk factors, treatment, survival, and then we're going to go into cholangiocarcinoma briefly, which is really cancers involving the bile duct. You can't start any conversation about gallbladder or bile duct cancers without first looking at the structure or the anatomy of the biliary tree and its function, really. So I have this image here, which kind of outlines the function or the anatomy of the gallbladder, the entire biliary tree. You see the liver basically is drained by these ducts, and the liver really has, even though it's one large organ, it has 8 segments, and each of those segments are independent segments. They function independently, and each of them has their own blood supply, their own bile duct that drains them, and also their own venous drainage. And so all of these then coalesce to form larger bile ducts. And so the bile ducts are here that drain in the liver. And so each of those segments drain into these ducts, and they eventually form what we call first order ducts, or the right and left bile duct. So this is the right bile duct, the left bile duct, and they come and they join and form a common hepatic duct. And think of it as starting in the liver and it's draining down. And so this common hepatic duct then is joined by this cystic duct, which basically drains the gallbladder. Where the cystic duct and this common hepatic duct comes together, it forms what we call the common bile duct. And the common bile duct then goes through the pancreas and is joined in the small intestine, or the duodenum, by this duct from the pancreas. And this area here is called the ampulla. Now, the whole purpose of the gallbladder is really, it's a storage organ. And bile is produced by the liver and is produced in a continuous manner. And that passes through the ducts, and it gets stored in the gallbladder when we don't need it. And the whole function of bile really is to help with fat digestion. So whenever you eat a fatty meal, then that those fats come into the small intestine. Bile is then, which is produced by the liver, stored by the gallbladder, is then a signal is sent to the gallbladder to push that bile out, to then mix with the fat to digest the fat. So really, that's what the whole purpose and function of the gallbladder is. Now, the gallbladder is somewhat specialized and is different from the rest of the bile ducts in that it's able to take a whole lot of the water out of the bile that's produced by the liver. And in concentrating the bile, sometimes when you have an imbalance of the constituents of the bile, which consists of some cholesterol, um, uh, bile salts, and some other constituents that we call phospholipids. When you have more cholesterol causing an imbalance, and you have the gallbladder taking out all the liquid out of the bile or the water out of the bile, that's when we form stones. So a lot of people may be familiar with gallstones. And essentially, that's the reason why we form gallstones is because of that imbalance. And it's formed within the gallbladder because the gallbladder takes all the water out of the bile. And then because of that imbalance, it forms stones. So with that background, then we can go into understanding what happens with, this is moving, 1 second, with gallbladder cancer. Now, gallbladder cancer is very rare. I'll start with that. And it occurs mostly in the 6th and 7th decade in life. You very rarely see a young person with gallbladder cancer. As you can see, the incidence in the US is 0.9 per 100,000 in males and 1.6 per 100,000 in females. So females actually get gallbladder cancer far more commonly than males do. It does vary in geographical areas and also with ethnicity. And it's more common in places like Mexico, Central and South America, and other Western Europe and parts of Asia. American Indians and Hispanics tend to have more gallbladder cancer than do, let's say, African Americans or European Americans. When we look at the world incidence rate, standardized incidence rate, you can see in most of countries like Chile, Republic of Korea, they tend to have a high incidence of gallbladder cancer. But for the rest of the world, I mean, the incidence is not that common. It's actually a rare tumor. But what I'd point out to you, you can see that even here, that females are far more affected than males. And when you look at mortality, the mortality in females and males is much higher than it is the incidence. So again, this is a relatively rare tumor, affects more females than males. It occurs mostly in older individuals, and it tends to be very lethal. Now, when we look at the Bahamas, and I was able to get local data, and we have a cancer registry, which is located on Village Road. And this cancer registry collects data from all the major hospitals. So PMH has a registry, and when you combine cases from PMH and cases from Doctors Hospital and cases from the RAN, then all of that data is fed into the Bahamas National Cancer Registry. And so you could see from 2018, and that's when the cancer registry first started collecting data. And this is a combined data. PMH has been collecting data for a while. You can see that the numbers are very low in our population. You can see in 2018, we had 3 cases, 2019, 2, 2022. And in 2021, nothing recorded. Most registry data is usually a year or two behind, but the data we have here for 2021 is zero. I don't think that to be correct. I think during the pandemic, we saw a decrease in reporting to the registry. And so 2020 and 2021 somewhat can be skewed. But as you can see, it's a rare tumor. We don't see a lot of these. But what I want you to note is that all of these cancers occurred in females. An age range between 48 and 78 years old. The other thing about these cancers is that they often present very late. And there's a reason for that, and we'll go into that. So what are some of the risk factors? As we said, age occurs in 6 to 7 decades. Female gender, and we'll go more into that. Genetics, anybody with a family history of gallbladder cancer tend to also have a high risk. Patients with gallstones, and we'll dive into that a little more because I know a lot of people want to hear about that. Gallbladder polyps, and then abnormal anatomy, as I described to you, where the bile duct and the pancreatic duct meet. If that junction is abnormal, then that can increase your risk of developing gallbladder cancer. Obesity is a significant risk factor, and we know about the obesity data in our country. We have a significant problem with overweight and obesity, and so therefore, if you extrapolate that, and in fact, a lot of our females and males too, but when you think of females and a lot of people being overweight, you could see why our population could be at risk. And then there's some diseases like primary sclerosing and cholangitis, which is a disease that is a very specific disease that where you have chronic inflammation involving the bile ducts, and occurs in patients with ulcerative colitis. But that's a very, very specific disease that increases your risk of gallbladder cancer. So let's take a look at gallstones first. So 85% of patients with gallbladder cancer have some form of history of gallstones, right? And it is believed that the etiology or the reason or pathogenesis for gallbladder cancer developing in patients with gallstones is because of chronic irritation. The stones are there associated with bile acids, and this leads to changes in the lining of the gallbladder. Remember I said the gallbladder lining is very specific. It's there. It takes out all of the water out of the bile. But if you have chronic irritation of the lining, that lining then loses its function and starts to change into a different type of cells, and those cells then can become cancerous. And so that's one of the thoughts as to how gallstones can lead to gallbladder cancer. But overall, when you look at all patients with gallstones, though, the incidence of gallbladder cancer is only 0.5%. So while a lot of patients with gallbladder cancer would have had gallstones, only a small amount of patients who have gallstones overall end up getting gallbladder cancer. And what the literature shows is that it's really dependent on the size of the stones and the duration of the stones. So when you see people, the garden variety gallstones are usually small stones, small cholesterol stones. They very rarely go above a centimeter. But when you see these stones starting to go above 2 centimeters or more, and they've been present for longer than 20 years, that's when you can see that you start to get that change in the lining of that gall bladder wall. And that's then when patients can then see that transformation from the normal to developing gallbladder cancer. So, I mean, again, we have a lot of patients with gallstones, but not all of them will go on to develop. In fact, only a very small fraction will. And it takes many years, greater than 20 years, with large stones before you see any significant risk of developing gallbladder cancer. The other thing is polyps within the gallbladder. And polyps, they're just elevated lining. And so we know about colon cancer. We know about polyps that are within the colon that go on to cause colon cancer. It's the same here, because this is all the digestive system. And so you have this, what we call adenoma carcinoma sequence, where most of these polyps are benign, but if left over time, they can go on to develop cancers, just like in the colon. So the incidence of gallbladder polyps is estimated to be anywhere between 3 and 5%. The majority of them are benign or non-neoplastic, but then about 5% of them can be neoplastic. And what I mean by neoplastic is that they have malignant transformation or become cancerous. The thing about gallbladder polyps, though, is that the malignancy increases again with the size. We talked about size of gallstones and time duration, but with polyps, if you have a polyp in the gallbladder that's greater than 1 centimeter, that becomes something significant. And so whenever any patient has a polyp within the gallbladder and it's more than 1 centimeter, it's recommended that you have that gallbladder removed. And a lot of these are asymptomatic. Patients don't have any symptoms, and it would just happen to be an incidental finding. You don't hardly get pain or anything with gallbladder polyps. It's just that you just happen for some reason, for another reason, to get an ultrasound, and you would see a polyp in the gallbladder, and you look at the size, and then that is something that would cause us to then act. So totally asymptomatic. Whereas with gallstones, the gallstones can become symptomatic, and then that would bring attention to the gallbladder. But with polyps, they're usually very asymptomatic. The next significant risk factor is what we call a porcelain gallbladder. I mean, and the name speaks for itself, right? And this is where the gallbladder becomes calcified. It was first described in 1831. And it's a pathologic condition that involves a bluish discoloration and brittle gallbladder. It's almost like real porcelain tiles. And this is a result of calcium becoming deposited within the wall of the gallbladder. And whenever you see this sort of raises a red flag. And because this increases your chances, again, of getting gallbladder cancer. Again, this is very rare. And again, it occurs somewhere within the 6th decade of life. Females, again, are much more predisposed to developing porcelain gallbladder than males. And I have a picture here, and you can see, well, this is an X-ray. And if you see this X-ray, you can see the outline of the gallbladder, because there's all of this calcification that occur within the wall of the gallbladder. And same here, you can see this is a CAT scan, and you can see basically, I mean, this gallbladder is pear-shaped or plum-shaped, and you can see the wall lit up, and that's just calcium that's within the gallbladder. And when we see this, I mean, sometimes the patients are symptomatic, sometimes they're not. And again, it occurs older patients. There is a significant risk of developing gallbladder cancer in that situation. So this again is another specific problem or risk that occurs. And remember, we talked about the gallbladder and then the cystic duct joining the common bile duct. And remember, I said that the pancreatic duct usually joins the common bile duct closer to the small intestine, and they both drain into the small intestine. Sometimes when you have a malformation, because this is a malformation, where the pancreas duct actually drains directly into the bile duct, way away from the duodenum. And so you can see what happens is pancreas juice, which is supposed to be going into the duodenum to help with digestion, protein digestion and fat digestion, it ends up going into the bile duct and going into the gallbladder and causing significant irritation. So you can see how this, over time, with the reflux of pancreas juice into the gallbladder, it would lead to chronic irritation and cause increased risk of developing gallbladder cancer. Obesity, again, defined by a BMI of greater than 30. It shows an increase risk. And the reason for this is because of the excess hormonal environment that is produced, and especially in postmenopausal women. So premenopausal women get their estrogen from the ovary, but once you become postmenopausal, the estrogen is produced from fat cells. There's this enzyme called aromatase that exists within the fat cells and is able to then stimulate or cause production of estrogen. And so postmenopausal women do have that excess amount of estrogen, especially if they're overweight or obese. And also you do get insulin resistance, and you have this hyperinsulin environment. And so this estrogen and insulin together in obese women creates this, what term we use is carcinogenic hormonal environment. And then that not only increases risk for gallbladder cancer, but other cancers too. For example, breast cancer in postmenopausal women. It's because of the same environment. And also, postmenopausal women who are taking hormone replacement therapy, especially if they're taking estrogen alone or even with progesterone, these hormones tend to increase, although a small increase, but they do cause an increase in risk. Studies have shown, however, if you do the transdermal patch rather than taking the oral pills, it kind of reduces your risk of gallbladder cancer. And again, primary sclerosing cholangitis, which is an inflammatory disease of the bile duct, and it occurs in special genetic situations and in patients with other inflammatory disease of the colon, like ulcerative colitis, and they tend to have an increased risk of getting gallbladder cancer. So when we kind of summarize the risk, you can look, say gallstones. And so gallstones increases your risk from anywhere from 3 to 23 times your relative risk. But that is very specific in terms of the size. Once your size of the gallstone is above 2 or 3 centimeters, then your risk actually becomes significantly increased. Duration of gallstone in terms of years, if it is that you've had gallstones for a long period of time, more than 20 years, that then increases your risk of gallbladder cancer. Body mass index, I think we kind of went over that, and you could see in our community why this could be a problem. And again, disproportionately affects females. And you recall from our registry, at least in the Bahamas, the majority of patients who have gallbladder cancer, well, all, not the majority, all, are actually females. So how does this present? Well, more than 50% of patients with gallbladder cancer is found incidentally. And that is they have symptomatic gallstones, and they get the gallbladder removed because of the gallstones, and they are then found incidentally to have early gallbladder cancer. And to be honest, this is this is the only way that you have an early presentation, because the majority of these patients present late. And by the time they start having right upper quadrant vague discomfort, or malaise or weight loss, we call it dyspeptic syndrome. By the time they have all of that, it's usually late. So if anybody, well, I mean, you don't wish this on anyone, but the way that we discover gallbladder cancer early is because we're treating gallstones. And it's just incidentally we find something in the gallbladder, and that's an early gallbladder cancer. And sometimes that is all that is needed to treat it, to remove the gallbladder. And sometimes if on imaging, if patient presents with significant symptoms, a mass in the gallbladder or liver on imaging, and by the time patients with a history of gallbladder cancer become jaundice, and what jaundice is usually is produced by a backup of the bile. Remember, I said that the bile is produced by the liver and is drained into the bile ducts and stored into the gallbladder before it's released back into the small intestine to aid with fat digestion. If along that egress from the liver, there's some sort of blockage, then the bile backs up in the liver, and then it backs up in the blood, and that's how people get jaundice. And the way you notice the jaundice is the yellowing of the eyes, the urine becomes dark, the stool becomes pale. And one of the things that is really annoying to patients is that they itch, and it's the worst itch that they'll ever have. And a lot of medication cannot soothe that pruritus, we call it, but itching. So when we look at gallbladder, I mean, you got to look at the staging of gallbladder cancer. And if you look at this diagram here, the gallbladder is very thin walled, and but it has a lining, and then it has a muscle layer. And the stage of gallbladder cancer really depends on its progression from the inner lining through the muscle layer and then outside of the wall of the gallbladder. And because the gallbladder is in such close proximity to the liver and it's so thin, the minute it punctures through there, you could see in this area here, because if this is the liver I'm pointing at, the minute it goes through the wall, it's already in the liver. And when it's in the liver like that, it's at an advanced stage. The duodenum or the upper part of the small intestine is also in very close proximity to the gallbladder. And so there are two surfaces. There's the liver surface, and then there's the duodenum surface. And so it can grow directly into the liver or directly into the duodenum. And that is what gives it a more advanced stage. Now, remember I said the majority of them are found incidentally. For example, if it is just within the lining of the or the inner lining, and those patients have gallstones and they present with pain because of the gallstones, and you take that out, then that cures it, as long as it has not gone beyond that inner lining of the wall. The other thing about gallbladder cancer is that it spreads fairly rapidly to lymph nodes. And once those lymph nodes become involved, it becomes exceedingly difficult to cure gallbladder cancer, and the survival goes down. So the T stage, or the depth of the wall, is what's significant. And then the spread to the surrounding lymph nodes. And lastly, if it's spread outside of that area, for example, to go to the liver, not directly, but other areas or other parts of the liver, if it spreads there, or if it spreads to the lung, then we know that that's stage 4 disease. So how do we treat? Well, again, early, localized, meaning if it stays within the wall. And usually these patients are patients who have gallstones, and we take it out. We didn't know that they had gallbladder cancer, and they had a simple cholecystectomy, and that is sufficient as long as it has not gone into the muscle layer. And there are numbers assigned to this. They call this a T1A. But if it goes any further in depth, then it becomes locally advanced. When it becomes locally advanced, a simple cholecystectomy or simple removal of the gallbladder is not sufficient anymore, because as long as it goes through the wall, it then gains or access to the blood vessels, the lymphatics, and goes to the lymph nodes. And when it does that, then that's when you have to remove all of those lymph nodes. And if it goes into the liver, then you have to remove a part of the liver. So that is when it becomes what we call locally advanced. And if it spreads not directly, but indirectly to other parts of the liver or parts of the lung, then that's stage 4 situation. That's palliative. And those patients tend not to do very well. So again, if it is confined to the, so cholecystectomy is just the medical term for removal of the gallbladder. And if it's an early stage gallbladder cancer, as you can see here, if we just removed the gallbladder, and again, we didn't know that there was a gallbladder cancer. That person just had stones. We just went there to remove the gallbladder to take care of the stones, and voila, we found an early gallbladder cancer. That's the best scenario. And those patients don't need any further treatment. They just need follow-up, and that's it. But like I said, once it goes a little deeper within the wall of the gallbladder, then we have to do what is called a radical cholecystectomy. The initial one is called a simple cholecystectomy. That's what we do for treatment of gallstones, and incidentally for small gallbladder cancers. But then we'll have to do a radical. And the term radical always means we're doing more, okay? And in doing so, we have to take a portion of that liver out, and we have to go and chase those lymph nodes and clear all of that area. The thing about these lymph nodes is that they become very prominent, and they then can block the bile duct. And that's when patients tend to become jaundice. And like I said, jaundice is a very late sign for somebody with a with a gallbladder cancer and usually represent a poor prognosis. So when you see someone with jaundice because of the gallbladder cancer, that's usually not that's a poor prognosis and very difficult to treat. So again, same theme, localized disease. These are the people who would get a simple cholecystectomy. If their lymph nodes, if we do harvest lymph nodes and they're positive, they have to get adjuvant chemotherapy and radiation. If it's a more locally advanced, meaning it's going into the liver, going into the duodenum, and we have to remove all of that area, again, they get a stronger type of chemotherapy and radiation associated with it. If it's advanced disease, as we discussed, then usually there's no surgery involved. Or if someone's just symptomatic, we do some kind of palliative surgery to try and relieve some obstruction to the bile duct. And there are different ways of doing that. But in advanced disease, there's usually not a surgical option to treat, but rather just chemotherapy. And that's what we call palliation. And palliation is just basically assisting people with symptoms so that to relieve pain, to relieve jaundice, helping them with if they have decreased appetite, treating in that way. Survival. Well, survival is really depends on the stage, of course. Overall, when you look at, and this is a database in the US they call SEER, and they looked at all patients from 2008 to 2014 by sex and stage. And as you can see, the dark line is male, the lighter line is lighter box is female. And when you look at overall, and I would say to you that this reference kind of, I believe, overestimates this because it's 5-year survival. When you look at other references, 5-year survival for gallbladder cancers overall is like somewhere around 5%, somewhere between 5 and 10%. But this SEER database they showed it 18%, which is, I think, very generous. But when you look at localized, meaning it's just involving the wall or maybe a little further in the wall with some sort of catching it early, the 5-year survival. And what I mean by 5-year survival, this is like in 5 years, this is how much people are surviving. So obviously it means like 40% of people that would have died within that time frame, but 60% of people would continue to survive, and this is with treatment. So you could see localized, even when it's just localized, there's still a significant amount of people that die. When it goes to the lymph nodes or regional, that we call it, you can see that we're looking at 25 in females and 26 in men in terms of 5-year survival. And distance. And again, I'd say to you, in my experience taking care of these patients in the Bahamas, the majority of these patients present at regional or distance. You very rarely get these localized, but they present regional and distance. Again, because a lot of the time, early symptoms, and if you ignore, you have gallstones and you ignore that and you go on, or if a mass develops and you have no pain, then people don't present. People don't seek medical attention. So when they present so late, there is really, and anywhere in the world, there's really not a whole lot that you can do. And so you could see that the dismal survival is 25, 26 when you have lymph node involvement. And this is with aggressive treatment. This is with surgery and chemotherapy and radiation. And when it's distant, meaning that it's spread not directly, but to different areas, and you can see that hardly anybody survives 5 years. And so again, this is a very lethal tumor if it goes unrecognized. And prevention is very difficult, but to be aware of certain things in your body is the only way to try to treat this. So in summary, gallbladder cancer is a very aggressive disease. It usually has a poor prognosis, and it usually presents with advanced disease. And I think that's why we struggle to treat patients with gallbladder cancer because they present late. If they present early and we just doing a simple gallbladder removal, then that's fine. And you can see even with that, you're looking at 60% survival. More common in females, and more in 6th to 7th decade. Predisposing factors are like stones. If you have stones for greater than 3 centimeters, greater than 2 to 3 centimeters for a long period of time, 20 years or more. If you have porcelain gallbladder, gallbladder polyps, greater than 1 centimeter, obesity, and then certain deranged anatomy. All of these increase your risk of gallbladder cancer. Now, I'm going to pause there because I know that was a lot. And ask if anybody have any questions on gallbladder cancer before I get into, and I'm not going to go into much detail about cholangiocarcinoma because that's even rarer than gallbladder cancer, but just to kind of give a high level overview of it. But is there any questions related to gallbladder cancer?
Maisie has a question. Go ahead, please.
Hi. Yeah, I was having difficulty unmuting. Good evening, everyone.
Hello.
Good evening, Dr. Francis. In your presentation, I never heard you mention pain. Is there pain at any stage of gallbladder cancer? And if so, at what stage does pain present?
So, as I had mentioned, patients who have gallstones usually present with pain. And so while that's a symptom of gallstones, that is the early trigger to suggest that something's going on in the gallbladder. But that's not a specific symptom of gallbladder cancer. So you just happen to have the stones there. The stones are causing blockage of the gallbladder, and that is what is giving you pain. And then you seek medical attention there, and you then incidentally find a gallbladder cancer. That's the best and the most commonest scenario to find. When it is that patients are outside of that scenario, it's usually that they come in with some sort of weight loss, some sort of loss of appetite. They may have some sort of discomfort, and then they present with jaundice, and that is usually a late finding. So the pain is not directly related to the gallbladder cancer, but more so to the gallstones, if that makes sense.
Dr. Francis, I know a lot of people, particularly recently, I hear a lot of people complaining about this acid reflux. Is there any connection? Is that like a trigger or a sign or a symptom in any way?
So acid reflux is basically something separate, but people who have gallstones tend to have what we call dyspepsia. or dyspeptic symptoms where they feeling that very discomfort in the upper aspect of the abdomen. And sometimes it's associated with what we call GERD, which is gastroesophageal reflux, and that's what the whole acid reflux thing is. Remember, the demographic is all the same. People who have GERD tend to be overweight, to have some issue with the whole mechanism as to what prevents us from getting reflux of stomach contents into our esophagus, because that's really what is the whole GERD symptoms. And so there's overlap between the symptoms of gallbladder disease and strict GERD. See Richard with his hand up.
Yeah, Richard, go ahead. Richard, if you can unmute yourself, you can ask your question. Dr. Holliday, are you able to unmute him?
Should be able to unmute now.
Okay, because Richard, if you are able to, you can unmute and ask your question. Or whoever is known as Richard's iPad.
Well, Richard could probably catch us up a little later.
Or put it in the chat and we'll ask a question
we could
for you.
ask a question later.
Yeah.
So, I mean, we could move on to cholangiocarcinoma, which again, and I'm not going to go into too much detail because it's very technical, but it's similar to that of gallbladder cancer. And again, it's really, so we talked about the gallbladder, and if you look at the image here, and so gallbladder cancer starts within the lining of the gallbladder, and then it essentially grows from there. So picture now the bile ducts. And so the bile ducts, there are ducts in the liver, there are ducts outside of the liver. And so we call them intrahepatic and extrahepatic. The ones outside of the liver, basically the right side of the liver is drained by the right duct, and the left side of the liver is drained by the left duct, and they come together to form a confluence. That confluence, and you can see it right here, goes on to form what we call the common hepatic duct. And then that is joined by the duct coming from the gallbladder. And then when those two join, they then form the common bile duct. So whenever you have a growth that occurs within these ducts, this growth is malignant. This is called cholangiocarcinoma, or cancer of the bile duct. And the presentation varies depending on the location. So, for example, if you can see here, intrahepatic, again, these are the terms within the liver and outside of the liver. So you can have intrahepatic cholangiocarcinoma, or ICCA. And then this area where the right and the left duct come together to form that confluence, and that area just above where the cystic duct or the gallbladder joins, that's called a perihilar cholangiocarcinoma. All right. And so when you have at that juncture, you have a growth there, then that is causes a significant problem. When you have a growth that grows lower down, anywhere below where the gallbladder joins the common hepatic duct, then that's called a distal cholangiocarcinoma or the distal bile duct. Each of these presents in a very different way. Now, whereas with the gallbladder, remember I said that in the gallbladder, by the time you get jaundice, is really advanced. That's because you have a lot of lymph nodes that block up this duct. But now you have something inside the duct causing blockage. So the initial symptoms for these patients are jaundice. And so they tend to get jaundice early. And the jaundice basically is where the eyes turn yellow, urine turns dark, the stool turns pale, and they start to itch. And this is what causes them to seek medical attention. And initially, most patients or would think that these are gallstones that may be causing the jaundice, but then on further investigation, they find a mass in this different area. Now, cholangiocarcinoma, again, is very rare, even more rare than gallbladder cancer. And the treatment involves a lot of surgery because as you can see, this is a highly specialized and technical area. The easiest one of these to treat really is the distal ones. And again, if the patient comes and they have jaundice, they got a CT scan, we discovered that this is distal cholangio. That is usually within the pancreas. And we have a procedure for that called a Whipple procedure, where we can remove the pancreas, the duodenum, and including this duct. And most of these patients can be cured. When we have this area here, perihilar one, that becomes very, very difficult because then you have 3 ducts sometimes involved, and the cancer grows along the duct and it creeps along the duct, and when that can then creep up into the liver. So when you have to deal with cancer of the perihilar area, you have to be able to remove a portion of the liver and all of these ducts, and eventually reconstruct the remaining duct that's not involved. And that's a big deal. I think in the last year, we had one patient with that, whom we were able to remove half of his liver, because the right side of the liver, the tumor was growing into the right side of the liver, and the left duct was free. So we were able to remove the right side of the liver with all of the duct system, and then connect the duct draining the left side of the liver to the small intestines, and he has done well. When you have it within the liver, this intrahepatic cholangiocarcinomas, then a lot of these patients tend to require transplantation, and it's very difficult to treat them. And only if they're very early, very small lesions. And a lot of times they're not jaundice. So when we see them, they come late because they've had some sort of weight loss, they've had some sort of pain, and then they get a CT scan and you see this big mass in the liver. So whereas the ducts get blocked and you get jaundice, and that's an early sign. When you're in the liver, you don't get jaundice so quickly. And so it's a delayed presentation. And so those patients tend not to do very well. And most of them require transplantation or liver transplantation. Needless to say, we don't offer that here. And so as you can see, cholangiocarcinoma and gallbladder cancers overall carry a very poor prognosis. And again, we have the ability to treat gallbladder cancers, especially when we catch them early, and cholangiocarcinomas if they're distal and perihilar region here. And again, the risk factors are similar. One of the risk factors for cholangiocarcinoma, which we see often, is patients who have the same primary sclerosing cholangitis, PSC, because they also have ulcerative colitis, which then can form PSC, and then they come and get cholangiocarcinoma. I think those are really the patients that we end up seeing. And there's a few sporadic development of cholangiocarcinoma. So I'm not gonna, I know our time is almost gone. We're gonna get into all of the weeds of cholangiocarcinoma, but I hope I would have presented an overview. And really, if you look at this, it's a plumbing issue, right? Because these ducts become blocked by tumor, and we have to remove that area to unblock them. And the closer it is to the liver, the more complex it becomes to do that. So I will stop there. And hopefully I didn't lose a lot of people, but I'll entertain any other questions as it relates to gallbladder cancer and also cholangiocarcinoma.
Anyone with questions, please feel free to either put them in the chat or you can unmute yourself and ask them directly. No questions, comments?
Clear as mud.
Last call. Okay. So Dr. Francis, I guess you did that good a job. No questions, eh?
How do you unmute? Am I on mute?
Oh, you are now. Go ahead, Richard.
Well, I was just asking some friends of mine in London now about
it's
Eastern
Manturin.
people. Hi. About East. That was a great talk, by the way. And it's a rare disease, of course. But asking some of my Oriental friends here in London, they said, wow, they see quite a bit in places like Singapore and Hong Kong.
South Korea.
Because
South
of
Korea
the
Singapore,
liver fluke. Yeah.
Yes. Yeah, we don't see liver fluke around here too much. And to be honest, like Southeast Asia, parasite caused this, like liver fluke, especially cholangiocarcinoma.
Yeah.
But that's just something that's, I think in all of my years in Western side of medicine, I've never seen the liver fluke. So we don't see it that often. And thank God for that. But obviously, South Korea, also places in Latin America like Bolivia. I think the initial slide that I show you can see the incidence is very high in those patients, and that's because of the presence of liver fluke.
Yeah, there are about 2 common liver flukes, I think, here, which in Singapore and Malaysia. I think they're I can't remember the name, but I think one of them is Clonoris or Clonokis sinusia, and the other one is
Clonoris clonoris. I didn't.
That's it. That's the one. I cannot pronounce it.
It's a tongue twister.
It is a tongue twister.
Right.
But that was the other part. Was great talk. Thank you very much indeed. And I was determined to stay up till 12:30, 1 o'clock to watch this.
Yeah. Oh wow. Well, thank you, Dr. Ventura. Good to hear you.
So we have a question in the chat from Vanda Ramming. She's asking if there is a test we can have done. I'm imagining a screening.
So no, there's no screening test. But again, like I said, how do we prevent this then, right? There is no screening test that says we can treat or screen for gallbladder cancer, like we have a mammogram or we have a colonoscopy for colon polyp. It's just having the awareness, okay, if you have gallstones, deal with them. If you happen to come across a polyp in your gallbladder, don't wait on it. I mean, I think for us, patients with gallbladder polyps, if they're less than a centimeter, we tend to not recommend cholecystectomy immediately, but we follow them for at least 2 years. Every 6 months, we do an ultrasound to see if there's growth. And among those patients, about 25% of them actually do grow. After 2 years, if they're not growing, you just leave it alone. But if they grow, then you would remove the gallbladder. When you think about obesity as a risk factor, and the whole, especially in postmenopausal women, that's another whole thing. That's just about improving lifestyle and trying to exercise and reduce calorie intake. It's not an easy thing. We all struggle with that. But it certainly is up there on the risk factor scale for gallbladder cancer. But there's not one particular screening test. We do, there is a tumor marker, but that's already if you suspect that a person has it, and we can use a tumor marker to sort of follow their treatment, or if after they've already been treated to determine or follow to see if they have a recurrence.
Thank you for that. Any other questions?
Can you hear me?
Yes.
How do you advise your patients that I tend to do quite a bit of ultrasound, looking more for fatty liver. And if you find some of them have gallstones, how do you recommend them? Would you recommend to get their gallstones out if they are about 1 centimeter, or as you mentioned, you follow them up every 6 months or every year?
So two things. The ultrasound follow-up is for polyps, right? So if patients come with gallstones and they're symptomatic, then we usually recommend that they have surgery. The majority of people with gallstones, in fact, are asymptomatic.
Yeah.
And when they do become symptomatic, then the chances are they're going to continue to be symptomatic, and then they get treatment for that reason. But there's no, if you incidentally find somebody with gallstone and they have no symptoms and the gallstones are small, again,
that's the one. Yeah.
I mean, I don't always recommend surgery in that case. Especially if they're small gallstones, people can adjust their diet, and sometimes because a good number of gallstones remain asymptomatic. But certainly if you start to see a stone greater than 2 centimeter up to 3 centimeter, that's concerning, and you should recommend cholecystectomy. I think cholecystectomy has become such a, for lack of a better term, such a safe procedure in most hands that we do a lot of it. But I think you only would do it for patients who are symptomatic. At least that's been my practice.
Yeah.
Because every now and then one of them could go wrong, and I mean, cholecystectomy, a simple cholecystectomy that's gone wrong is really a bad situation for patients. So when do you do it if you need it, right? At least that's my philosophy.
It's just that I saw one, I think, long ago. Actually, he was admitted to doctors, and he had a gallstone that perforated into his duodenum. Yeah.
Yes, that's a different situation. That's called a cholecystoduodenal fistula, another tongue twister, and that requires another type of treatment. All right, thank you.
Right. Thanks a lot. Thank you.
Dr. Francis,
Yes.
what about fatty livers? Is that something to be concerned about, and or what do we do about it, or how do we?
So fatty livers, fatty liver is something to be concerned about. And I mean, obviously, the name is self-explanatory. I mean, there's a lot of fat deposited in the liver. Remember, the liver is a storage organ, and the liver really produces glycogen for the body to for its own fuel. And if you take in more than you actually need, it gets stored in the liver as fat. And that can cause significant derangement of the liver. Now, fatty liver can also occur with alcoholism. So what happened is that you have non-alcoholic fatty liver, or NAFL. And what happens is that can go on to develop cirrhosis, just like how the alcoholics can develop cirrhosis, because alcoholics have fatty liver initially, and then they develop cirrhosis from that and go on. So if you get a whole lot of deposits of fat, and this is a non-alcoholic version, it can do the same thing. They can go on to develop cancer, but a different type, not cholangiocarcinoma. It's called hepatocellular carcinoma. So fatty liver is a significant problem if it goes unchecked or untreated, but there's some medication for people, obviously dietary manipulation and caloric intake, exercise, but then there's also medication that they use to treat that. But it is a problem.
Okay. Okay. I don't see any more questions in the chat, and so we'll give one more call if anyone has any questions. Okay. So if not, then I would like to thank you, Dr. Francis, for the time tonight. As you said, it's not a very common cancer, but certainly one that we should know more about, because I guess like everything else, we probably may start to see more of it in, coming time. Particularly, I guess the obesity is something we tend to hear a lot of in these meetings. And we know that that's a chronic problem here in our country. So I think it's it all goes towards us all trying to change our lifestyles, eat better, exercise more, cut down the drinking, cut out the smoking, all those things, so they go a long way. So thank you so much for your presentation tonight. And I'm sure the information has been useful to everybody. So we'd like to thank everybody who took the time to join us tonight. Quite a good crowd. Thank you all. And we'll be back again next month. And our date for next month is March 12th. So stay tuned, keep checking the website. We'll keep you updated on who our next speaker will be in our next topic. So we hope to see you all again next month. In the meantime, stay safe and keep looking out, keep taking care of yourselves. Thank you once again, Dr. Francis, and good night.
Good night.